Please welcome the host of the longest running live daily talk show in LA history. They actually have a birthday coming up, an anniversary, 38 years on the air on Saturday. Please welcome the host of AirTalk, Larry Mantle.
Thank you so much. It's wonderful to be back at Caltech, and thank you for coming out tonight. Fortunately, we didn't have rain as you were arriving at the auditorium tonight. It's great to have you with us, and it's a real honor to be here in this beautiful venue at Caltech. My thanks to Michael, who does so many great programs here. And if you're not familiar with his work before coming here to Caltech, he really built Grand Performances downtown, which has an extraordinary array of performances at California Plaza, and he's just a tremendous cultural gift to greater Los Angeles. So it's a real honor to be here in the house that he programs. And Becca and her team, John Cohn, who's not able to be with us tonight of our live events, it's a real treat to get to work with them. They are simply the best. And all of us on the AirTalk team, and there are a number of us here tonight, appreciate what a pleasure it is to work with such professionals. I have been looking forward to this evening for months. We've been planning to bring the doctors together, finding a date that would work for those that are out of town to come down and join us from Sacramento and the Bay Area, and others to join us locally. So to finally make this happen is just a wonderful experience. You might have seen the question cards that were out in the lobby, and we'll go through those and have, after we do the radio broadcast portion, we'll ask some of your questions that you've got this evening. And speaking of the radio broadcast, this will air tomorrow morning. We're going to do a fast turnaround on it. It'll air in our 10 o'clock second hour tomorrow morning during AirTalk. Well, I made the decision not even to spend time in the green room with the doctors tonight, because I wanted this to be fresh for me too. I'm so excited to see them. So my experience, aside from a brief sound check that we did, is going to be as fresh as yours. So I'm going to introduce them actually on the live radio broadcast, because I want the radio listeners to vicariously enjoy the affection that I'm sure you're going to show the doctors for their work when they come on. So we're going to get going. I just want to let you know, I know it's public radio, but if you feel like applauding when I start the radio broadcast or go to breaks, I'll give you a little cue. Please let it rip, because it's going to sound great on the radio. I know it'll mean a lot to the doctors. From Caltech's Beckman Auditorium, this is the AirTalk COVID Doctors Retrospective. I'm Larry Mantle. It's a short trip, as we're just 2 miles from our AirTalk studios, but surrounded this evening by a few hundred people at Caltech to hear from these physicians who've been such a key part of our AirTalk COVID-19 coverage. Now, I'll never forget March 11th, 2020. That's the night the NBA shut down. MLB announced the next day that spring training was going to be suspended. Concerts and other public events were canceled. It was a whirlwind. But of course, we were well aware of COVID-19 prior to that happening, months earlier. We'd started booking infectious disease specialists about how hard they thought this novel coronavirus would hit the U.S. We were learning about how quickly the virus could be spread and the respiratory dangers for many who became affected. Nevertheless, for me, March 11th, 2020, was the night the pandemic arrived in full force in a way that would change our lives even these 3 years later. Throughout the pandemic, AirTalk has benefited from the generosity of more than a dozen medical professionals who've shared their expertise and time to update us on COVID-19. And the 6 who join us this evening are among our most frequent COVID experts. You will likely recognize their names. We begin with UC Davis Children's Hospital pediatric infectious disease specialist and professor of medicine, Dr. Dean Blumberg. joining us from Sacramento.
Thank you, Larry. So happy to be here, and really congratulations on your upcoming anniversary, 38
Thank you.
years. That's quite an achievement.
Thank you, Dr. Blumberg. Thank you. Also with us from UC San Francisco Medical Center, infectious disease specialist and professor of medicine at UCSF, Dr. Peter Chen Hong. The Dr. PCH fan club is in full force.
So great to be here, Larry.
Our third expert is Professor of Nursing and Public Health at UCLA. She's also a registered nurse who practices at Gateways Hospital in Echo Park, Kristen R. Choi. Dr. Choi. From Orange County at UCI Medical Center, she's professor of medicine at the School of Medicine there, associate medical director for epidemiology and infection prevention, Dr. Shruti Gohill.
Great to be back.
From UCLA's Fielding School of Public Health, professor of epidemiology and community health sciences, he was the head of communicable disease control and prevention at LA County Public Health for many years, Dr. Robert Kim Farley. And as so many of these physicians, more professional credits and accolades than we have time to share with you, but their resumes run very deep for all of our guests. And finally, the closest to us, from just over at Huntington Hospital, Director of Infectious Disease and Prevention, Dr. Kimberly Schreiner. All right, well, let's get right into our questions for this evening's program, and I want to begin by asking each of you, who've made such huge contributions to our program, just briefly, each of you, what's the biggest way that COVID has affected your professional life? Dr. Schreiner, just very briefly, what's the biggest way it's affected your work?
I think it's made me realize that we have to be humble in the presence of something that we didn't know very much about, and that we have to follow the science, and that we need to create an environment that's safe for our healthcare workers to work in, and to go forward with as much information as we have and make good decisions together.
Dr. Kim Farley.
Being on your show, Larry, and being able to have the time to actually talk with people on an extended basis as compared to the press or in the TV. So I think that's very good, and to be very responsive to people's concerns. I think that's one thing you've brought for us.
Well, thank you so much. Dr. Gohill.
Yeah, in my professional life, this is a field that we have, healthcare epidemiology and infection prevention is steeped in the response to things like pandemic and many other things. And we came from a relative obscurity where every hospital has a team like ours. We went from relative obscurity to, front-facing with all of our physicians and brought the entire hospital together in really an unprecedented way. And that's changed our professional lives, yeah.
All right, Dr. Choi.
You know, it's changed many things for me about my life as a professor, but I think the biggest impact for me is actually in my work as a nurse. It's changed how I practice, how I talk to patients and families, and it's changed very much how I think about my responsibility for the future of nursing and the future of healthcare and what we need to do differently moving forward.
Dr. Chen Hong.
I think I became an unexpected activist using science. So if it was, racial inequalities or tear gas or Asian hate, I think I found myself in the center of that, but using science as my core.
Dr. Blumberg.
I've always been working to take care of patients and make sure that they have the best outcome, but I spent more time during this pandemic to really spend time trying to protect healthcare workers too, and making sure that they were safe during the pandemic, and realizing this is the last pandemic I'm going to go through.
All right. Well, let's talk about the state of COVID, where we stand now, because people are still dying from COVID-19, although the death rate is significantly lower. The vast majority of people who are dying from it are people who are older and who have comorbidities. They're vulnerable. to a variety of different illnesses, including COVID. So, Dr. Gohill, where are we at in terms of the pandemic? Do you say we're through it?
You always ask the hardest questions.
Of course.
Yeah, never say never, but gee, how far have we come, right? Peak after peak, we've seen this roller coaster, up and down, up and down. What's different now are the deaths are stable. Hospitalizations are stable. And this is in large part due to the layers of immunity that have been achieved through vaccination, and of course the infection itself. And so I do think we're in a different place because it's 2 or 3 strains in a row, and you see the hospitalizations stabilizing and the death stabilizing, and so we're higher than what we like to see to call endemic COVID. A little bit higher, but we are stable, and that's good.
Well, and Dr. Chin Hong, are we close to the point where, like with pneumonia, we know that people that are older and have other illnesses are particularly vulnerable. Many people die of pneumonia, but they were at death's door, so to speak, before they contracted pneumonia. And are we close to that point with COVID-19?
I mean, we're not exactly there yet for a couple of reasons. One is that the numbers are still too troublesome for me because I think the number of deaths, when you think of where that plane will land into 100,000 to 150,000 a year, just seems a little bit troublesome, particularly given the tools that we have. And the second thing is, I don't feel that we're exactly predictable yet. And this is all in the context of, maybe about 20% of people embracing the new booster, while others are asking for an additional booster. So I think there are a lot of paradoxes, but yes, we have the tools. We know what we need to do, so we can treat it that way, hopefully.
We're coming your way from Caltech's Beckman Auditorium in Pasadena, bringing together 6 of our COVID-19 experts who've joined us throughout the course of the 3+ years of this pandemic, and we're delighted to have them here in front of an audience at Beckman Auditorium to talk about how they've been affected professionally by COVID-19 and also to share the latest science where we are. What do you consider the greatest ongoing mystery of COVID-19, Dr. Kim Farley?
Well, I think a couple of things that's still a mystery is the arising of variants and when the next one may arise. I think that's always a concern we have, and what will be the characteristics of that as it arises. Will it evade our vaccine immunity or our natural immunities? So I think that's one of the mysteries that still is out there, and we will have to see whether we can actually get to that endemic phase or not.
Dr. Schreiner, what's the biggest mystery for you?
Yeah, I would agree with that. I also think, though, that we need to, it's really a mystery as to what this virus does in the immune system, and that really seems to be the key of what creates the symptoms that people have when they have COVID, and of course, leading on to a really dreadful syndrome of long COVID, which we do see in about 30% of people who've had acute disease. So this virus is very good at integrating itself into the immune system, and the complexities of that, I think, we're just beginning to understand.
Dr. Blumberg, do we have a good handle on who's most vulnerable to long COVID? Is there any way of predicting that?
We're still learning so much about long COVID, and I'd just like to second that's one of the biggest mysteries is why does this virus cause so much long COVID? We know that other viruses can trigger things like chronic fatigue syndrome, but it's so way out of proportion with COVID causing this long COVID. It's affecting patients in so many different ways. When you see these patients and how their lifestyles totally changed, it's really something. So that's something that I really think we need to invest in.
And of course, with long COVID, there's significant mental health repercussions to that, just like any sort of long-term condition, whether it's chronic fatigue or whatever it is, particularly if there are people skeptical about the patient's symptoms. And Professor Choi, I wonder if you can speak to that, and what are healthcare professionals learning about the way of dealing with this? For example, with long COVID, has that made perhaps physicians and nurses more understanding of people who present with symptoms of chronic fatigue?
Yeah, it's a great question, Larry. I think sometimes, yes, we do know that there is an intersection between mental illness and long COVID that we're still trying to understand, the reasons why these things happen together or why we see them occurring. I think that we are still trying to get a handle, too, on the mental health side of this pandemic. And I think that's one aspect that we still have a really long ways to go. It concerns me when I look at the rates of suicide, of depression, and anxiety, especially among our teens and young people in the United States, because those metrics are just getting worse and worse and worse. So we have work to do on long COVID and the intersection of mental illness, absolutely. But I worry, and it troubles me a lot, that we haven't quite learned the lessons we need to about mental health from COVID yet in terms of our health system. So I still want to see us go a little further there.
I mean, it just seems to me a natural thing. If someone is dealing with the debilitating experiences that come with long COVID, like with some of these other chronic illnesses, that of course that's going to have an effect on a person's mood, on the state of being. But then it's easy for people to turn that around and to blame a patient and saying, oh, that's the reason why you're still sick. And so I guess, my question, Dr. Kim Farley, is, are we getting out of that?
Yeah, and I think this issue of mental health is also not just from, again, long COVID and situation, but we've had a lot of mental stress in our societies, loneliness, isolation, children not having, again, the opportunity for face-to-face interaction at young ages in school for a couple of years. So we're facing those issues as well.
Yeah, and Dr. Blumberg is a pediatric infectious disease specialist. What is it going to take for kids to make their way out of this? Some, of course, have been highly resilient and maybe will be back to what they were pre-pandemic, but for many kids, that's not the case.
Yeah, so many kids just lost out on school experiences, not only the learning, but the social experiences. And so there's this whole generation of kids that missed out on those growing experiences and those experiences that they need to attain maturity. And also the isolation that they experienced was severe. So there's a lot of catching up to do among children, the young children as well as teens.
And what can parents and schools do to help in that process?
Well, now things are back to normal, and so getting back to normal, but kids are catching up, and so they're really learning, but they missed out on, for example, socialization during kindergarten or preschool, and now they're having to catch up with all that. So it's a really interesting time.
I was doing a panel with professional educators, and all of them were saying that classroom behavior has become much more challenging for teachers since kids have come back. And I know, it's been some time now that kids have been back in the classroom, but do you think that, kids are going to end up back, in a more comfortable place like they were, or is this generation going to have lingering effects?
I'm hoping they're going to catch up. It's not only the younger children, but we worry about that, for example, in medical school and the residents in training, and they missed out on so much during this time because they didn't have interactive conferences in person, and many of the experiences they had during the pandemic were so aberrant. So I think during this time, we're really curious to see how they do catch up and what sort of experiences that they do have in the future.
We're coming your way from Caltech's Beckman Auditorium, just a couple of miles from our LAist 89.3 studios. A large number of LAist listeners who are joining us tonight to hear from 6 of our COVID-19 experts who've been with us throughout the course of the pandemic, and it's a great opportunity for us to show our appreciation and to hear more of their expertise this evening. Dr. Chin Hong, among healthcare workers, this has been a tremendously challenging time. What's happening at UCSF Medical Center? Are things back to what they were before?
No, far from it. I'll give you some examples. I liked what Dr. Bloomberg said about education suffering not only in K-12 or in college, but also in medical school and in residency. So much so that there was less of a community in all of this, and there was less of a community amongst clinicians. We don't even know some of the new hires. Yesterday, one of my colleagues and I went to the Golden State Warriors game at Chase Center with a group of trainees because we wanted to build that community, and the trainees didn't know each other by face because they only saw each other through masks, and there's so much physicality that you have in body language. So things are far from back to normal. I think people are still suffering. People are operating out of mental exhaustion. There's moral injury because we're still taking care of patients who aren't subscribers to some of the tools that we have to keep them safe, and that's hard.
Well, I was going to say, I assume, some natural resentment, and for people that are doing this work, putting themselves at some degree of risk, and then to have patients who are in dire shape, not vaccinated, perhaps haven't taken other precautions to try and prevent. And no healthcare professional wants to be blaming the patient, of course, but an emotional response to that is natural. So how do professionals deal with that?
I think, it's easy to say, throw up your hands and say, I'm not going to see you, or engage with the family members, but actually it's the opposite. Because, there have been several cases where, talking to family members, I'll give you a scenario. A parent is in the ICU with severe COVID, and the family comes, and you engage with the family about what's happening, and you see the patient and the family over multiple days. And eventually, actually, with that relationship that you built, the family who were previously not subscribers of vaccination began to turn around by not only seeing their loved one in the hospital, but also by the relationship and the conversations you've had with them. So I think, empathic listening or humble inquiry is so key, even though it's so difficult. But it does make you feel better at the end of the day when you do have these success stories, when, of course, you focus on the negative, the hateful comments, or the requests for ivermectin or hydroxychloroquine. But again, there are all these silver linings as well.
Professor Choi, we've seen an exodus of many people from the healthcare professions, including nursing. What's going to be the way to attract people either back to the profession or more young people being trained to come into it?
Yeah, this is also something that keeps me up at night. And if I'm being honest, there were times when I contemplated leaving nursing and thought that my clinical career would end during COVID because of the conditions. It was a really challenging time. I think that we have to look really carefully at what are the drivers of our workforce shortage in healthcare, and how can we tackle those things. And people say to me all the time, can we just train more nurses? Why don't you just double your class at UCLA, get more nurses out the door? But for a lot of professions in healthcare, it's actually not an issue of the numbers. By the numbers, we have the number of people. The problem is that we have a shortage of nursing care and physician care because people are leaving, because working conditions are simply not sustainable for people. So
and
I think
an aging population, which probably
absolutely
more patients are coming in.
Absolutely. People are living longer, sicker, the work is harder. So I think that we have to think really carefully about healthcare as a system. How do we create the conditions to make sure that people can sustain careers in healthcare and they don't come in the door and burn out? Now, I'm not worried about the pipeline. We have thousands of bright, talented people applying to UCLA, UCSF, UCI, UC Davis, wanting to become nurses and physicians, more than we can take. So I'm very hopeful about the people coming in. I'm more thoughtful about how do we make sure that those people who have energy and ideas and want to come in and make a difference don't walk in the door and then walk straight out when they realize conditions are unbearable for them.
Well, and I don't recall exactly when it is. I'm sure you'd know. When we had the acute nursing shortage in California, and the nursing schools, community colleges were trying to expand nursing programs, and my perception of that time is that compensation also increased in the field of nursing. And I'm not saying nurses are appropriately paid now, but at my recollection, it was worse before that shortage. And I wonder if we're now at a period where the need is so great, are nurses and other healthcare professionals more in the driver's seat to be able to negotiate for those better terms of employment?
Yeah, absolutely. I think so. Certainly with the rise of travel nursing, we've seen a lot of changes to nursing salaries. I was just talking to Dr. Gohill about this, but some of our hospitals in Southern California are 30 to 40% travel nurses. Wow. And while there's progress in that these nurses are being paid a wage that's more fair for the work they're doing, the challenge is that it's sort of a gigification of nursing, where we have a lot of turnover of those nurses, and we don't have people who have the institutional knowledge and experience that we know is so critical to providing good patient care. So the rise of travel nursing, I think, is helpful in some ways, but it poses challenges as well.
We're coming your way from Caltech's Beckman Auditorium. A pleasure to be the guests of Caltech for this AirTalk broadcast. We're on the road bringing together 6 of our COVID-19 experts to talk about what's professionally changed in their lives, the latest on COVID-19, and what's happening in the healthcare profession. Dr. Gohill, you're the head of infection prevention, and hospitals have had to grapple with deaths from infection and trying to bring those numbers down and control. Has that improved as a result of the conscientiousness over personal protective equipment and having patients more serious about masking and the like? Has that helped overall rates of hospital infection?
Absolutely. It went 2 ways. Nationally, in hospitals, we are seeing an actual increase in multi-drug resistant organisms and other things that we used to keep at bay. And on the one hand, we saw a national increase during COVID. On the other hand, amongst healthcare workers, I would say our nursing staff and our physician staff, everyone, all hands on deck, everybody came together and understand principles and concepts in infection prevention in a way that I think it's different now. So this is a wonderful consequence. Now getting back to our bread and butter, we have a lot of work to do. Decreasing bacteremias in patients who are hospitalized, multi-drug resistant organism-associated infections, ventilator-associated infections, all of those things are back definitely. And I do want to circle back on
Sure, yes.
One of the questions that how has the hospital come out of it, and what's burnout really looking like? It's now that the face has changed just a little bit. COVID-associated hospitalizations are down, but all those patients that receive suboptimal access to care or delayed care because of the pandemic are on, I think every hospital's filled up. Our ERs are bursting at the seams, unfortunately. And it really does contribute to this domino effect of healthcare worker fatigue and burnout. And I think we're still in it. Though the world has moved on, I think we're still in it. Yeah,
all right.
That way.
Dr. Schreiner, I wanted to ask you, since I mentioned masking in the hospital environment, your thoughts about where we are on best practices for masking. When should we still be wearing them?
I knew I'd get the mask question.
There was that mask.
And you were prepared for it.
And I was prepared for it. For the Huntington people who are out there, they know where I stand on masks. I guess
Just move your mic just a touch closer.
It's really important. I just want to circle back for 1 second on what Dr. Gohill said, because I think it's really important, is that there's so many layers of healthcare. There's the community. There are the physicians in the outpatient world. There's the hospital. There are the skilled nursing facilities. There are the emergency EMT and the first responders. And we're all integrated. And so when there's a backup one place, it just becomes a domino effect through other places. So one of the reasons why we have such a long wait in emergency rooms is because we can't get patients discharged from the hospital because the skilled nursing facilities are filled up. All of those places also need really superb PPE and simple protective things that we can do. We can test patients if we need to. We can screen patients. We can provide good PPE. Remember, at the beginning of the pandemic, we had a huge shortage of PPE.
Yes.
And we had very generous members of our community here in Pasadena that got masks from China and brought them in and so forth. We didn't understand a lot of the dynamics about masks. What's a KN95? Now everybody knows what a KN95 is, what an N95 is. But we understand that better now from going through the pandemic, and that's actually helped not just diseases like COVID, but other upper respiratory infections like influenza, tuberculosis, and so forth. I think that masking is a very easy, very safe, very effective way of protecting yourself from COVID. There's a lot of COVID experience now in the world. Everybody on this planet has had some brush with COVID. Either they've been vaccinated, or they've had the natural disease, or they've had both. So I think now we have to move into more areas where we can control the actual encounter with the disease. We don't have vaccines that can prevent infection, but we have masks, and they can prevent infection. And they can prevent infection with other diseases as well. So it's important that the public understand when we kind of toggle back and forth, wear your mask, don't wear your mask, it's in relation to what we think is circulating out there, that masks can be effective and protect you. I think that as we move through this, hospitals are trying to sort of match their masking mandates with what's going on in the community, which is okay, but hospitals have to have a much, much higher standard for the people that are inhabiting that hospital, healthcare workers and patients. So we're changing, for example, at Huntington, we'll be changing some of their masking mandates that visitors don't have to wear masks. We might recommend that they do. They're coming to a hospital where there's lots of vulnerable people. But we really want to try to keep it at this point, as Dr. Ferrer from the LA Public Health Department has proposed, that we keep masking going on in hospitals for a while longer until we're sure that we really are this thing is beginning to settle down a little bit.
That's Dr. Kimberly Schreiner, Huntington Hospital in Pasadena. Also with us at Caltech's Beckman Auditorium for this AirTalk on the Road broadcast, Dr. Robert Kim Farley, UCLA Fielding School of Public Health, Dr. Shruti Gohil, UC Irvine School of Medicine, Dr. Peter Chin Hong, UC San Francisco Medical Center, Christian Choi, UCLA, and Dr. Dean Blumberg, UC Davis Children's Hospital, all joining us on this special program. Did I see someone else want to? Yes, Dr. Kim Farley.
I just wanted to follow up a little bit on this too, because also masking in the general public is another issue. And I think that everyone is going to have to recognize their own particular situation. So if someone is immune compromised, for example, they're going to have to continue to be masking up. And I think the real important thing is for all of us to recognize we should not stigmatize people for wearing masks. So that's an important thing as well.
I like it when I go to the market and I see there are people wearing their masks, and just like it's normal, other people who choose not to do it. I think it's great we're at that point, and hopefully, as you suggest, that people aren't going to feel stigmatized and that people don't feel it's their business to tell other people, that why are they wearing a mask? That's ridiculous. Hopefully, people are beyond that sort of thing. I guess time will tell.
Yeah, in fact, it's a situation, too, that some people I've found that, for example, if they have something important coming up in 5 days or so, bar mitzvah or christening or whatever, they may choose to wear masks just to make sure they don't get COVID at this time that could then interfere with their plans.
Dr. Chin Hong, if we could go back in time to 3 years ago, what messaging from a public health perspective would we change?
Well, I think we had no idea, first of all, that we would have so much misinformation, disinformation. This has been a pandemic of social media in many senses. Social media is good too. In fact, when the CDC was silent for much of the early pandemic, and that gets to your question on messaging, we as clinicians had to share our best practices on social media. In fact, that's how I even got into this communication in the first place. We were sharing information on how we would diagnose people clinically, because we had not enough tests. It was like if you only checked people for HIV, if they had PCP pneumonia or Kaposi sarcoma, there was this whole lot of people in the community with COVID that we didn't know and we couldn't see. So I think that coming back to those early days, first of all, I think we underestimated in terms of messaging what that role of the other non-science-based people would be, and we weren't, I think we didn't have enough artillery to really, it kind of took us by surprise. The second was we weren't specific enough. I think when I went to the farmer's market early in the pandemic, there were maybe 20 things that were suggested as to how I needed to protect myself from COVID, whereas it just boiled down to maybe 2 or 3 things. And I think just seeing the forest for the trees was really tough for people in the beginning. We didn't use enough trusted witnesses from the community. I think, we had the fake or the false security that people would listen always to clinicians, but that's not always the truth, particularly in minority and vulnerable populations. I think having a clergy member or somebody from the community was probably more powerful than somebody from a healthcare facility at that point. So I think there are many lessons we can learn from communication, and we have to be very specific and apply that.
The flip side of that, though, is that you had so many of us who had to learn so much, and people learned a lot in a pretty quick period of time. So, yes, there was plenty of misinformation and outright conspiracy theories that were being promulgated. But I wonder if, as an epidemiologist, Dr. Kim Farley, you can speak to that point. I can't ever think of a time where so many people have been right at the forefront of the general public of learning about something like this.
I think you're right, and I think, again, your program helps get some of that right information out from the colleagues around the dais here. But I think that the other thing to realize is that we still in public health need to do a better job in the communication. I think we failed in one sense of setting people up that there is going to be change in our guidance as we go forward. Number one, it's a brand new virus, and we're finding out more about it, and as we find out more about it, our guidance is going to change. Number two, the virus itself started changing on us with different variants, so that will also change. So I think that somehow that often got put in the minds of others as flip-flopping, as compared to getting out ahead of it and saying we're going to have these changes going on.
Well, and I think early on, and maybe Dr. Gohill, you can speak to this, public health faced a real challenge because of the shortage of PPE, particularly masks. So the messaging to the public was, well, we're not sure masks or for the general public are that big a deal. And the sense that I got was that much of that message was because they didn't want the general public going out cornering the market on all the masks so that healthcare professionals at greatest risk would be unprotected. I think that message, though, led to a credibility problem for public health because people thought, oh, that was the real reason they gave that message, because we know with airborne infections that masks make a difference. And your thoughts on that, giving that message early on?
I think absolutely right. Getting ahead of the game is absolutely critical. But and more to your point here with masks, we have to acknowledge that we've learned a lot in healthcare epidemiology and in public health. This was a massive culture change. Let's not forget where we were. You know, masks didn't have the cachet and clear data that it has now in terms of both community masking and hospital masking. You're absolutely right that the people who needed them most were the healthcare workers on the front line. That's the bottom line. We know that. But the fact that community level mask and transmission, pandemic after pandemic, we went through H1N1, and there was a run on masks for sure, but that cultural, social, community level appreciation for the need for masks wasn't fully recognized. So I'm not sure it was a complete public health message to sort of let's keep all the masks together for our healthcare facilities, as much as, well, is it really our front line of defense? And now I think all of us have come around to really, really recognizing it.
Dr. Blumberg, were you going to say something on that?
Yeah, I just have to say, I think we did lose control of messaging, in my opinion. I mean, we know that the three most important things for protection are masking, distancing, and vaccination. And yet we did spend an inordinate amount of time talking about hand washing. Now, I'm pro hand washing. I think hand washing is great, and it prevents a lot of infections, but including RSV, but it's not that big a deal with COVID, and including things like sanitizing groceries, increasing ventilation. Those are important, but those are this much important, whereas the masks, vaccination, and distancing are this much important.
Dr. Blumberg, I wanted to ask you, going back to kids and COVID, do you think schools, in hindsight, made a mistake in closing? Or do you think, given where we were with COVID, it was essential to close schools because of the risk, particularly to teachers?
I think we had to close the schools in retrospect, and that's based on what happened when we saw the experiences that were going on in New York City, in India, and Iran, in Italy. There's so many different places where the healthcare systems got overwhelmed and people were dying because there was a lack of supplemental oxygen. We couldn't allow that to happen, and we know that children can serve to amplify community-associated infections. We know this occurs with influenza, that they don't suffer as much from that, but they do transmit throughout the community. So schools would have been a hotbed of transmission before we had masking policies in place, before we had immunizations in place, and that would have led to more transmission throughout the community and more deaths, and the healthcare system wouldn't have been able to treat patients.
Why do you think, though, that we saw, with schools, at least in this country it seemed, where the spread typically occurred, it was brought from home more than it was spread, say, among faculty members of a school? Why was that?
I think most of the transmission that occurred was in the community, but there were, and once the schools did reopen, there were several outbreaks that did occur in school, and kids did end up bringing it home to the families. But for the most part, when family transmission, it would be the parents out in the community who were unprotected, and then they would bring it home and infect other family members. But it did work both ways.
We're coming your way from Caltech Beckman Auditorium. Larry Mantle with a special hour of AirTalk with our COVID-19 experts, 6 of them joining us on stage this evening at Caltech for this special program. Let's talk about the science of COVID right now. First of all, Dr. Schreiner, Paxlovid, what are the pros and cons of its use? What do we better understand about that treatment for COVID now than we did when it was first introduced?
Well, I think it's important, first of all, to recognize what an achievement it is during this very, very amazingly terrible pandemic that we developed a test to test for the virus very quickly. We had the genomic information within weeks after the first outbreak in Wuhan, and a vaccine was an effective vaccine using a 20-year-old technology that had really never been tried and on a grand scale was super effective, and that happened within about 8 months of the onset of the pandemic. That's an enormously important achievement. A lot of that was built on the backbone of the HIV pandemic because we had PCR, we knew how to measure RNA viruses in particular, and we knew how to develop not so much a vaccine, because we still don't have a vaccine for HIV, but we had the possibility for developing effective antiviral therapies. Paxlovid, which is really, I think, proving to be the first of that family, is a protease inhibitor, which is in the same family of many of the HIV medications. They're very safe, they're very effective, and although I think this is just the first of many, hopefully, it's going to be an important part of controlling this pandemic because it's very effective. It decreases symptomatology and infectiousness very quickly. It may protect a person from long COVID, and it certainly may get them feeling better and back out in the world. There may be a role for Paxlovid or other anti-SARS-CoV-2 medications in the treatment of long COVID. I think that there may be some element of persistent virus, and that's where it will be effective. So I think it's a really big and important development.
There's some members of the public who have the perception that Paxlovid causes rebounds of COVID, and I know that's been studied. Is that true?
There's very good data to show that whether you take Paxlovid or not, there's a risk of rebound. So in individuals who don't take Paxlovid, they can rebound with more symptoms again a few days later or 4 or 5 days later and test positive again. That's a natural behavior of this virus. It doesn't happen in lots of people, but some people. So Paxlovid doesn't appear in any way to increase the risk of rebound.
Professor Choi, I wanted to ask you about where we are on vaccination because NPR reported that the FDA is considering approving a second dosage of the bivalent booster for people who are higher risk, either because of their age or underlying conditions. And it looks like for others of the population this fall, perhaps, will be the recommendation for an annual. Your thoughts about that schedule of vaccination?
Yeah, I think that makes a lot of sense. I think many of us have anticipated that this may become an annual booster that we all get going forward. So as we talked about earlier, I think we're at a place where this virus in many ways has become endemic. It's something that we're seeing starting to stabilize more. And, knowing the seasonality that there is, it makes sense to me that we would potentially have a seasonal booster.
What do you think, Dr. Chen Hong?
I agree with Professor Choi. I think it's going to be interesting politically how it will turn out. We know, of course, that the UK has allowed immune-compromised individuals of all ages and those of us 75 in Canada, those over 80, to have the option of a booster before the fall. So that's a could rather than a should recommendation. So I think the FDA will probably respond to a lot of public pressure, peer pressure to do something similar, but you wouldn't probably see a sort of full-on population campaign until the fall.
Yeah, Dr. Kim Farley.
And we may see some real work being done already. Manufacturers are working on this. Two vaccines in one, flu and COVID. So I think we'll see that coming up too, which will make it a lot easier.
And I don't know if you happen to see, I think it was published in a journal recently about a graphene strip that within just seconds or a few minutes can detect if you have flu or COVID, differentiating, which would seem like a testing game changer if that could be mass produced. I don't know if any of you have heard about that, but sounded very promising. Dr.
I mean,
Chin-Hong.
I love the idea of doing more at-home testing and patient-centered testing, particularly for flu, because I think we've kind of ignored flu. But remember, early flu diagnosis leads to Tamiflu, which is the Paxlovid of influenza. But we hadn't been sensitized as a community to really think about it as much. And I think coming back to some of the enduring legacies, masking, but I think early therapy is really another legacy of what we've learned from the pandemic.
Dr. Gohill, do you think that people should have access to a second bivalent COVID booster before the fall?
Well, I think certainly those who are at risk. I think that the guidance is just spot on for that, absolutely.
All right. Let me ask you, Dr. Blumberg, about how you feel like medicine overall has been affected by COVID-19, because we've heard some examples, different medical centers, attrition of professionals in the field, but I wonder about the relationship between the patient and the physician. Has that changed as a result of COVID?
I think a lot of patients have really appreciated all healthcare workers being on the front line during this pandemic. So they appreciate nurses, doctors, respiratory therapists, anybody really who's been working in the hospital. They realize that many of these healthcare professionals put themselves at risk. And I have to say, during this whole pandemic, I didn't hear anybody say, any healthcare professional say that they were like afraid of getting COVID. They were afraid, they wanted to take the appropriate measures, but nobody said, I'm not going to see that patient because I'm afraid of getting COVID. People wanted to be there. That's why people went into the healthcare profession. So I saw a lot of appreciation for that from the public.
All right. Dr. Chin-Hong, what about for you? Has anything about the way you practice medicine changed?
Well, I think I missed the sort of physical aspect of being in the room with the patient. I love talking to people, and I would give outpatients like recommendations. So we'd trade stories on where to get the best coffee in San Francisco. I mean, you can do it over Zoom, but it's not the same as drawing the diagram on the paper. So I think I'm looking forward to getting back to that. It is fun, though, to be, well, the sort of silver linings of being a healthcare worker during the pandemic, and particularly being on your show, Larry. I'd go to a boba shop, and then people would recognize me and want to give me a free boba, or maybe I'd get an appetizer at the Italian restaurant Che Fico. So, I mean, I latched on to these joys, but yes, I mean, the hospital, it was a lot of work, but then, there were these fun aspects too.
Professor Choi, for yourself as a professor and a practicing nurse, anything changed?
Yeah, like I mentioned earlier, my own practice as a nurse has changed a lot. I think I have become personally more willing to spend time with patients and families than I was before, to know that if I take the time to sit down and have a conversation with someone and see them where they're at, even if I feel myself getting behind in my day or, thinking through the list of things I have to do, that time is what is most critical that we spend with our patients. So that has changed for me. The other piece, though, is that when people come and I talk to patients and families, I think so much more about their context and where they're coming from. One of the big things that this pandemic has helped us see is the way that we have so many upstream factors that have driven the inequities we see in COVID. And we've seen inequities from day one, and who is getting infected, who can access vaccines, who can access treatments. The same groups have disparities and don't have equal access to care. And so when I see those things, and I come from a practice where I work in a safety net hospital and work with a lot of people who have many of these social vulnerabilities, I think a lot about where people are coming from and how we can design a healthcare system that is going to be responsive to those things versus just looking at people only as individuals and not thinking so much about their context, because that context really matters for our health.
Yeah. I appreciate that you raised both those points. Dr. Gohill?
Very much in line with my thinking as well. I mean, it's definitely in hospital epidemiology. Certainly, I work on the wards as an infectious disease physician. The two things that have always been abundantly clear are, of course, the disparities and also the borders of our hospitals are really so not the borders. And really, we are part of a huge community of people, and we're accountable for that, right? And everything that we do in our hospitals really should think about the total care of a patient from the beginning all the way through their discharge and their wellness, and God forbid if they come back to us. So, yeah.
Dr. Kim Farley, I mean, you have the experience of being with so many different organizations, major national organizations over the year, leadership position, LA County Public Health, and now professor at UCLA. I mean, for this point in your career, to see how something like this has affected the whole healthcare system, our understanding of pandemics, it's got to be particularly remarkable for you.
Yes, it really is. I mean, this is a unique time in all of our lives here, audience and ourselves included. I mean, this is probably the biggest pandemic we will see in our lifetimes, I hope. But at the same time, we recognize now we've got to be more and more prepared for these potentials to occur. We are moving into areas in the world that have been previously uninhabited. We've got the transportation systems that in 24 hours you can be anywhere else in the world. I kind of think of it like, we're a body, we have a brain, and the brain says, oh, well, I have a sore in my foot. Well, I don't have to worry about that. That's the foot's problem. No, because that can give a septicemia and end up killing the brain and all. We need to think of the mankind, and humanity is the same way. We need to be caring just as much, making sure that child in an African village is vaccinated as we are in our own country. We're all interdependent.
So appropriate you say that, because Dr. Kimberly Schreiner of Huntington travels regularly to Africa to provide health care services. How has this affected the way that you provide your care?
Well, I think just building on what everybody has said, I think that this really ultimately is a journey that we've all taken as Homo sapiens. This is something that we all share, whether you're a physician or a nurse or a public health person or a patient or just anybody on the planet. There's a commonality here that I think is really important, that it's an opportunity to really take a good look at what we do as human beings, how we interact with other human beings, how things can be unfair in the world, and we need to do something about that. And also we need to be good stewards of the planet. This event, which was a really dramatic event, pandemics often create a lot of change. We have to try to find the good in it. For all the people that we lost to COVID, their legacy is that we've learned so much about virology and talking to each other. All these professionals that are on this stage here, we might not have had these conversations where we have a pediatric infectious disease doctor and 2 ID docs and a nursing school coordinator and public health people and the people that we talk to. It pulls together this teamwork that we have to do. And I think that's what we have to try to get something good that came from this. We have to pay attention to what we've learned, to be prepared for something else. I hope Dr. Kim Farley is right that this is the last big pandemic that any of us experience, but something could happen tomorrow, and we need to be ready for that. And I think that this has taught us a tremendous amount of lessons, and I think we just take that forward to try to do a better job the next time we have to deal with this.
All right. Yeah.
And
Dr.
if I might
Kim
say,
Farley.
the vision you've outlined, I think, is so important about that interconnectedness, that fact that we have to all work in partnership. And that's the one, I think, disappointing thing for me with the COVID has been, this was the greatest opportunity to have a world solidarity. We're all fighting a common enemy. To have national solidarity. This shouldn't have become bipartisan or issues. One administration created the vaccine. Another administration was deploying it. We should all have been on the podium together, shaking hands and saying, this is the greatest success story we have. Instead, we've been left with, unfortunately, this division.
On a lighter note, I wanted to ask, do any of you have a good story about being recognized because of your name or your voice, because of all the times that you were on AirTalk? Anybody have a good, Professor Choi?
I have a pretty good one. During COVID, I'm someone who likes to hike and rock climb, trail running. I do all that stuff. And at one point, I think it was in 2021, I was out rock climbing with my fiance in Malibu. We were in a pretty remote area. And when we were walking back, we were just chatting with some of the other climbers, and we were talking about COVID, as you did in 2021. And the person I was talking to said, I heard this nurse on NPR, and she was really saying something really important about the vaccine. And I looked at her and I said, I think that was me. So she was pretty surprised.
And she was really good. So that's another story from anybody about, Dr. Schreiner.
I was in line at the grocery store, and I was masked up, and everybody was masked up. This was fairly early, but I'd done several shows, and this woman standing next to me said, Dr. Schreiner, is that you? And I said, yes, and I recognized your voice.
That's great. That's great. I want to thank you. Oh, yes, Dr. Blumberg. Yeah.
I'm in Sacramento, and I've done some local TV there, so people know my face there from the television. In Los Angeles, not so much. But people from LA sometimes I'd talk to them on the phone, and they would just say, your voice seems so familiar, and I don't know where I've heard it. And I'd say, do you listen to Larry Mantle? And they'd go, oh, that's it. That's where I've heard it.
That's great. I want to thank you all so much for all the time that you've given us over the years and in the future. Dr. Dean Blumberg, Dr. Peter Chin Hong, Professor Kristen Archor, Dr. Shruti Gohill, Dr. Robert Kim Farley, Dr. Kimberly Schreiner. Thank you all. You have had a huge effect on our listening audience, on the hundreds of people that are here tonight at Caltech's Beckman Auditorium as well. It's AirTalk on LAist 89.3. I'm Larry Mantle. Wonderful to have you with us to share our event live here at Beckman Auditorium on the Caltech campus. Our thanks to the wonderful staff at Caltech, so great to work with, and also my ongoing appreciation for our wonderful AirTalk team of producers who are here tonight, always helping me be prepared and be able to do programs like this. So from all of us at AirTalk, have a great rest of your day. Those of you that are here live, stay, because we've got more to come. Coming up next, Here and Now from NPR. Thank you so much. We're going to continue with some questions from members of our audience. So I will await the arrival of those, and then we will go to those. Yeah. By the way, this gentleman here is our senior producer of AirTalk, Matt D'Angelantonio. You hear his name on air, and he leads our team at LAist 89.3. All right. So, this is from Babak in Irvine. What is the survival rate for patients on chronic immunosuppressants like, and I may be mispronouncing this, rituximab, who get COVID-19 infection? Who would like to answer that question? Survival rate. Anybody? Dr. Schreiner?
This is one of the things we're concerned about, and this is a population we're really worried about, are the immunosuppressed folks. There's so many people that have had organ transplants or who are on taking immunosuppressive drugs for cancer chemotherapy or for autoimmune diseases, and often they don't have a very good antibody response to the vaccines. They may have had 5 or even 6 vaccines that just they're not able to get their protective antibodies high enough. So we do worry about COVID in this population. That's why when you wear your mask, you protect yourself and you protect them. The chances of survival are hard to predict. It depends on what some of the other underlying problems are. We certainly have, it's worth trying things like remdesivir, antivirals, or Paxlovid. Unfortunately, the monoclonal antibodies, which we really used quite a bit to protect these people beforehand, the Omicron virus has now become quite resistant to that. However, there are some new monoclonal antibodies that are in trial right now that we're looking at to help protect our immunosuppressed population, and also to understand the dynamics of the virus in people that are immunosuppressed. It's different than in people who have a normal immune system.
And there's that the drug Evusheld, is it, that people who can't be vaccinated because they're not going to get a response that's going to provide immunoprotection. Is Evusheld effective?
Evusheld was effective until the Omicron family took over, and so that's really been a disappointment. But there are some monoclonal antibodies now that are being looked at, in addition to some other ways of stimulating the immune system so that these individuals can be better protected.
All right, Dr. Chin Hong.
I'll just add one more thing to that, which is that there's a movement by some in the interim in the immunocompromised provider community, including the Infectious Disease Society of America, to think about coming back to using convalescent plasma, because that convalescent plasma, for all of you who don't know it, is the antibodies we can harvest from people who were exposed naturally. So if now it's Omicron and we can harvest those antibodies and have a high titer enriched product, again, for those transplant patients, the Colin Powells, the people on rituximab who don't and can't make antibodies, that's their only hope for getting some sort of protection.
All right. This comes from Dr. Thomas Maurer of Kaiser Permanente in Los Angeles. How can we do better balancing personal liberty with public health concerns? improving the public health system? Who would like to? Dr. Kim Farley.
I'll take a first stab at it. I think one of the things that we've often been saying, and you've heard this, follow the science. And, really what we mean normally is biological science. But I think what we also have to realize, I think there are three sciences at play here. Biological science, how does a virus interact, how does it spread, et cetera. But also the behavioral science, how do people behave and how can we work with that? And social scientists and political scientists to figure out, what can be done. A lot of different ways were approached in different countries. I'm thinking at the beginning, for example, China was probably the best example of pure public health applied with forced isolation, forced quarantine, forced testing, but you could never do that here in the United States. And
I
even
assume
in
you're
China,
putting
it was
that
not
in
sustainable.
quotes when you say best public health, because here that, as you
Right,
say.
I mean, in terms of the pure public health practices, but without looking at these behavioral issues, behavioral science, political science. So I think we needed to balance those, and that's what happened, for example, with the amount of time for going into quarantine, reduced from 10 days to the 5 days. Only a third of people were following the 10 days. So better to get 5 days with more people following it than to try to do a longer period. So I think that we didn't use as much of the behavioral scientists, the political scientists, the social scientists, and the same thing in the social media sphere. We needed to make sure we were using social marketing, social media influencers, behavioral scientists to be able to craft some of these messages.
Professor Choi, were you going to say something? Yeah.
Yeah, and I totally agree. And I would add to that something Dr. Chin Hong said earlier, which is that, when we think about public health and public health response, so much of it is local, even though there absolutely is science and guidelines that we follow when we look to entities like the CDC and others. So much of the way it gets operationalized has a lot to do with a local community, with who is trusted, with what community entities and organizations already have that trust with communities. I had my students at UCLA do an assignment where they looked at mask messaging across different states, and it was really interesting to see how different they were. There was an ad from Wyoming that had a picture of a small business owner, and the tagline was "For now, not forever," and that was so different than what we were seeing in LA. And I think that there's a lot more that we can do, to Dr. Kim Farley's point, to think about how we leverage those tools of behavioral science as well, but also know that it's going to be different at different places, and one size does not fit all here.
Yeah, I think that's a great example, Professor, because for a lot of Americans, they don't want to be preached to, and they want to feel that they have some agency, not be told this is what you have to do. And so because you were talking earlier about the importance of people who are influential in communities, I think for that community for whom the personal freedom is a central part of their identity, there also need to be ways of crafting that message, as you say, like people showing, this is my choice. I'm doing this because it makes sense for me to do this as I move in the world. Anyone else want to comment on?
Maybe just add one more thing. I think on this issue, too, is that we have to work more also on the idea of doing things for others, a sense of community resilience and community solidarity for, wearing masks, not for just yourself, but for others.
Dr. Maher also had a question, and it's similar to what I brought up earlier about, he says, why the confusion regarding mask protection early on? We well understood how coronaviruses are transmitted. Anybody want to expand on what we talked about, Dr. Blumberg?
The studies, the scientific studies weren't there, so theoretically it just makes sense that the masks are going to work. But those studies, I remember the first good study that I saw that showed that masks protected, that was almost a year into the pandemic, when a meta-analysis was published in Lancet Infectious Diseases that took a whole bunch of studies all the way back to SARS-1 and MERS, the Middle Eastern respiratory virus, which is related, and COVID, and they put them all together in a meta-analysis and found that masks were highly protective. But that was a study that took almost a year to come out, and so we didn't have the data. We couldn't say.
You couldn't apply from other coronaviruses.
We couldn't. This was different. So we couldn't specifically say that masks will protect you this amount. We couldn't say that a standard surgical mask provides 50% protection, that an N95 among the general public will provide 80% protection. We didn't have those numbers back then, and so I think that, to me, that was a failing. We didn't have that. Now we've got the data.
Dr. Chin Hong.
I would say added to that was, in the beginning, it was the sense that COVID was other, so it wasn't in the community, and that was really because we couldn't see it. We had Vaseline on our eyes because we didn't have the diagnostic tests. So when the Surgeon General said, we don't think you need to wear masks in the community, it was the sense that, it wasn't that cruise ship outside the Oakland port, or it was in China, or it was in Italy, but then became closer and closer. So that's one thing. The second thing was that, we didn't realize that COVID, SARS-CoV-2 virus was airborne. We thought that it was like a respiratory virus where it would fall within 3 feet. So if you used social distancing alone, you'd be able to avoid it. So I think that's when ventilation and the idea of aerosolization came about. All of that happened. And again, it was getting more and more science as time goes on. And that frustrated a lot of people in the community, I think.
Dr. Gohill.
I do want to, piggyback on that and just say one of the biggest learning lessons, the other day job that I have is in research. And in real time, being able to develop science in a rapid way, the way mRNA vaccines came out within 11 months or something. We need to be able to, as a public health community, as a medical community, be able to, really escalate our research process in real time when these things emerge. And that was one, I think, major learning lesson.
Natalie of Los Angeles asks, how likely will a nasal vaccine be available, and what might the timing of its availability be? Who would like to respond? Nasal vaccine? Any? Dr. Schreiner?
I don't think we know yet, but that is going to be a very important thing. And I just wanted to say one more thing about some of the situations at the beginning. I think the other really big thing to build on Dr. Chin Hong and Dr. Cahill's, I think, is that we didn't know that SARS-CoV-2 was transmitted by asymptomatic people. That was a really important, sort of discovery, really. That so that really implicated the importance of masking and so forth, even if you weren't feeling ill. That this disease can be transmitted by asymptomatic folks. Which
and that's
is probably
different than, say, the flu, right?
Pardon me?
And that's different than, say, the flu,
Yeah.
right?
Yeah. So the nasal vaccines, I think, are a really interesting idea in that the portal of entry of COVID, of course, is in the nose, where you have a lot of ACE2 receptors, which is the main receptor site for the virus. And so there's a lot of work now focusing on using intranasal vaccines that stimulate the IgA antibodies, which are the first antibodies that respond to an infection on mucous membranes, to really prevent infection to begin with and to decrease quickly the amount of virus that you're carrying around in your nose so that you don't spread that to other people. India, I believe, has a clinical trial going on right now with a nasal vaccine. I think right now most of the nasal vaccines are not mRNA vaccines, but that could be a potential platform for that. But I think that could be a game changer. That really could be what pushes this virus into an endemic state and really sort of squelches off the pandemic if we have a vaccine that's effective.
Dr. Blumberg.
Yeah, and just to emphasize that, the current vaccines that we have do a great job of protecting against severe infection, but they do a crappy job protecting against infection overall. And that's why the nasal vaccines should provide better protection, because they would get immunity at the site of infection where it occurs. So I'm hopeful. On the other hand, we've had nasal vaccines for influenza for quite some time, and those were supposed to protect better compared to the injected vaccines, and they just have not fulfilled that promise. So I'm hopeful that this next generation of vaccines will be better against COVID, the nasal vaccines, but I need to see the data.
Elisa in Huntington Beach asks, what do you think about boosters being taken 6 months versus annually? Anybody? Dr. Chin Hong?
I can start with that. I mean, I think what we know, we don't have all the data about how the current bivalent boosters, how long they would last. So I think that's why everyone has a different opinion on the data we know currently. What we know what we have the most data for is the previous, vaccines, original variant vaccines, and the antibodies taper off in 5 to 6 months or 4 to 5 months. So that's kind of like what people are, debating about now. But I would say there are a few caveats. Number one, we're not measuring T cells, which are another kind of antibody cells, which kind of like are they have memory, and they are kind of almost like the covert operators that kind of come out of the woodwork, so to speak, once the enemy gets through the initial defenses. The second point is we don't really know, every time you get a particular vaccine, in other words, number 4 might be different from number 3, because every time you remind the immune system, perhaps that will last a little bit longer. So it may be that some populations, like the very immune compromised and the very elderly folks, may need more frequent, but the vast majority of people may need at the most once yearly for serious disease. If you want to think about prevention of infection, that's where you think about the nasal vaccine or some other strategy.
And I just don't think that that every 6 months is feasible. I mean, in the U.S. with influenza vaccines, only 50% of the population gets vaccinated yearly. So trying to do twice a year, I just don't see it happening.
But for certain people, they'll do it.
I think for certain populations, The other thing I worry about that, though, with many vaccines, you get hypo-responsiveness. With each subsequent vaccine dose, there's less of a benefit. And so there's always that risk, too.
All right. Other question, and I know this is going to be, it depends, but when is it safe to unmask regularly indoors? What are the circumstances? Maybe Dr. Gohill, when do you feel okay not wearing a mask?
I mean, I think that it really depends on what the community prevalence really is. It depends. And so when you're low enough, then you should feel safe enough that, if it's 1 in 1,000, that you probably wouldn't encounter it. So if it's low season versus a high season, I think that's really where the rubber meets the road.
Also, if you live with someone immunocompromised, I would think your masking standard would be considerably higher than someone who doesn't.
Absolutely, you're going somewhere special.
And I think also where you are indoors matters, right? So in healthcare, we're still wearing masks, and I personally feel like I'm just shocked we didn't do this before. Like, I think we'll probably continue doing that. So I think context matters a lot in making those choices.
All right. Well, I want to thank you for the questions that were asked by our audience. Thank you all so much for joining us this evening. Again, our wonderful physicians, thank you for coming out tonight to Caltech's Beckman Auditorium. Have a wonderful rest of your evening, and I hope you'll check out all the other LAist events that we have at laist.com/events, and you'll come out and join us for more of them. Thanks so much, and remember, you can tune in tomorrow morning, 10 o'clock. You'll get a chance to hear the program just without the audience question portion. Thanks so much. Have a great night.